Hello everyone, welcome to Patho Excellence. In this endometrial pathology video series, today we will discuss morphologic features in AUB or abnormal uterine bleeding. Abnormal uterine bleeding is a common clinical problem with many underlying causes. So in this session, we will focus on normal endometrial thickness chart, ideal time to take endometrial biopsy, FIGO definition and PALM-COEIN classification, different causes of endometrial abnormal uterine bleeding, and most important, morphological features of glandular and stromal breakdown in menstrual and abnormal bleeding. So first of all, normal endometrial thickness. In menstrual phase, it is normal 2 to 4 mm, early yellow proliferative phase 5 to 7 mm, late proliferative phase 8 to 11 mm, secretory phase 11 to 14 mm, which is optimal for implantation, and postmenopausal women without hormone replacement therapy, it is less than 5 mm. If it is more than 5 mm, may indicate endometrial hyperplasia or carcinoma and requires further investigation. Postmenopausal women with hormone replacement therapy, normal is up to 8 mm. If it is more than 8 mm, risk of some pathology and further evaluation is recommended. Now, what is the ideal time to take endometrial biopsy? So, first of all, the optimal site is the uterine fundus. Now, for the evaluation of infertility, day 21 of the cycle or luteal phase, which is 7 days after ovulation. Abnormal uterine bleeding, early proliferative phase, day 6 to 10 or after bleeding episode. Postmenopausal bleeding, anytime, urgent evaluation due to malignancy risk. Suspected endometrial hyperplasia or carcinoma at presentation, independent of cycle day. Suspected endometrial tuberculosis, anytime during the cycle, best during proliferative phase to avoid menstrual blood contamination, and multiple samples may be required. Chronic pelvic pain or infertility with TB suspicion, anytime, preferably during early proliferative phase for better yield. Previously, the terms were used like menorrhagia, metrorrhagia, or dysfunctional uterine bleeding. According to new FIGO definition, the new terminology is abnormal uterine bleeding. And nomenclature and the different uh, definitions for abnormal uterine bleeding include frequency, duration, regularity, and flow volume in menstrual cycle. So, normal is every 24 to 38 days. Frequency, suppose if it is absent or frequent, which is less than 24 days, or infrequent, more than 38 days. Duration up to 8 days is normal, more than 8 days is prolonged. Regularity includes variation, but shortest to longest is less than 9 days. Irregular variation includes shortest to longest is greater than 10 days. Flow volume, if it is light or heavy, which is included in abnormal uterine bleeding. So, by definition, uterine bleeding resulting from alteration in the normal cyclical changes of the endometrium that are not due to structural causes is included in abnormal uterine bleeding, and it excludes postmenopausal bleeding or bleeding caused by the presence of specific pathological processes such as inflammation, polyp, hyperplasia, malignancy, exogenous hormones, and complications of pregnancy. Now, PALM-COEIN classification, which is FIGO classification, includes structural causes of AUB, designated as PALM. Here, P stands for polyp, which is AUBP, adenomyosis, AUBA, L, leiomyoma, AUBL, M, malignancy and hyperplasia, AUBM. COIN stands for non-structural causes of AUB. C stands for coagulopathy, which is AUBC. Ovarian dysfunctional causes, which is AUBO. Endometrium, which is AUBE. Iatrogenic, AUBI. And N stands for not otherwise classified, AUBN. Now, what are the causes of AUB? In case of cervicitis, dysplasia, polyp or carcinoma of cervix, in uterus, leiomyomas, endometritis, endometrial polyp, adenomyosis or malignancy. Ovarian causes are mostly anovulatory cycles, ovarian failures or polycystic ovaries, and some tumors. Iatrogenic causes includes hormonal contraceptives, IUCD, hormone replacement therapy, etc. Some prolactinomas, thyroid disease, coagulation defects include ITP, von Willebrand disease, hepatic and renal failure, and pregnancy-related complications. If we see differential by age, so 13 to 18 age group shows most common cause is anovulation, then ossipils, pelvic infection, some coagulopathies or tumor. In 19 to 39 age group, pregnancy, structural lesions, anovulatory cycles, ossipils, hyperplasia and cancers are the common cause. 40 to menopause age group, here anovulatory bleeding, hyperplasia and malignancy, atrophy and leiomyoma are the causes for the AUB. Now, non-structural causes of abnormal uterine bleeding are frequent in perimenopausal and perimenarchal women and lesser extent in women of reproductive age. Now, this includes latter half of the acronym PALM-COEIN, which we have already discussed: coagulopathy, ovulatory dysfunction, endometrial, iatrogenic and not yet classified causes. These etiologies do not have specific histopathological findings except for ovulatory dysfunction and iatrogenic causes, which may show hormonal changes. So, by far, anovulatory cycles are the most common cause of non-structural AUB. Now, what are the morphological changes we can see under microscope? So, these changes are associated with the endometrial glandular and stromal breakdown, and they are extensive associated with AUB. Breakdown and bleeding patterns have been referred to by the several different descriptive terms such as lytic, shading, slough or even menstrual endometrium. So, microscopic features of irregular endometrial glandular and stromal breakdown includes stromal collapse, stromal cell clusters, fibrin thrombi, nuclear debris at base of the glands, nuclear debris in stroma, eosinophilic syncytial change in glands, hemosiderin, form cells, stromal fibrosis and hyalinization. Let's discuss this all point one by one. But before that, what is the difference between menstrual bleeding and abnormal endometrial bleeding? So, the histological changes seen in abnormal endometrial bleeding is usually associated with anovulatory cycles and it occur on a non-secretory background. and having heterogeneous pattern means there is presence of fragments of intact non-shedding endometrium along with endometrium showing glandular and stromal background. So, normal plus abnormal. While menstrual bleeding is associated with breakdown, but the changes affect all the tissue and occur on a background of late secretory phase glands. So this table shows the difference in the feature of menstrual bleeding and abnormal bleeding. So background endometrium in menstrual bleeding is late secretory, while in abnormal bleeding it is proliferative or secretory or some structural lesion is there. Heterogeneous background present in abnormal bleeding, absent in menstrual bleeding. Stromal collapse present in both the condition. Stromal cell cluster in the form of stromal blue balls present in abnormal bleeding. It may be present or absent in menstrual bleeding. Fibrin thrombi present in both the conditions. Nuclear debris at the base of gland present in both the type of bleeding. Nuclear debris in stroma mostly present in abnormal bleeding. Eosinophilic syncytial change, hemosiderin, form cells, stromal fibrosis and hyalinization is mostly present in abnormal bleeding and absent in menstrual bleeding. Now let's see all the morphology one by one. So stromal clusters. In this section we can see the stromal cells are aggregated into the rounded clusters and it is surrounded by RBCs. So, stromal collapse or clusters. Some glands showing poorly secretory change. Some glands are broken and stroma is also broken. So, this is the section showing glandular and stromal breakdown. And this is the abnormal bleeding pattern associated with chronic inflammation. And this is the cause due to retained placental site. So here we can see stromal blue ball formation. So proliferative endometrium and stromal breakdown. Here we can see only hemorrhage. Stroma is here present. Some broken glands broken gland is present, and here there is stromal collapse in the form of ball. So this is stromal blue ball. In this section, we can see stromal ball and some debris at the base of the cell of the in the cell glandular cell. So this is nuclear debris. So some nuclear debris in the stroma and in the gland. So this is again a case of glandular and stromal breakdown in AUB. This is the section showing syncytial change in case of glandular and stromal breakdown. These glands are showing extensive eosinophilic cytoplasm, indistinct cell border, and stroma is compact. So this is called syncytial change or eosinophilic syncytial change in case of AUB. In high power view, we can easily appreciate syncytium of the surface epithelial cells along with the breakdown of stromal cells surrounded by RBC. Here the syncytium shows round to oval nuclei and having uniform chromatic pattern. So this is again a case of AUB. Here Syncytial pattern is easily identifiable, but some abnormal or pseudopapillary-like structures are present in abundance. So this is pseudopapillary formation of glands, and this is a benign cause showing stromal condensation, stromal ball or stromal collapse, some edematous stroma, and these are the pseudopapillary structures and eosinophilic syncytial chain. Here, the syncytium of surface epithelial cells overlying the stromal component, and in this syncytium there is haphazard arrangement of nuclei and some of having a vacuolated cytoplasm. So this is a glandular and stromal breakdown with eosinophilic syncytial change. Fibrin thrombi. So in this section, weak proliferative glands present. Some are broken, but major feature is ectatic venule comprising of thrombin in the lumen. So this is the fibrin thrombi comprising of RBC, WBC and fibrinous material. So these are fibrin thrombi in case of AUB. This section again shows multiple ectatic venule containing fibrinous or fibrin thrombi, compact stroma, weak proliferative endometrial glands, and edematous and hemorrhagic stroma. In some case, endometrial form cells may be seen. This is due to a lipid liberated from the RBC lysing due to abnormal bleeding. So these are the benign form cells in case of abnormal uterine bleeding. In some cases of AUB, there is presence of increased amount of apoptotic bodies in the proliferative endometrial glands. And mitotic figure you can see in here section. This is due to dysregulation of proliferation and apoptosis, which leads to increase in apoptotic bodies, and this is common finding in some abnormal uterine bleeding. So whenever we find increased amount of apoptotic bodies along with some stromal hemorrhage and presence of stromal breakdown, we can suspect AUB. So in this topic, we have seen morphological features to describe abnormal uterine bleeding. Now we will see ovulatory dysfunction or AUBO in next topic. So I hope you will see or you will apply these microscopic features when you see endometrial biopsy slide, and you can easily differentiate menstrual bleeding and abnormal uterine bleeding. So I hope you like this session. So please like, share and subscribe and also comment. Thank you and stay tuned for this next topic.